On this episode of the ASC Podcast with John Goehle, we discuss the latest news and information, some recent survey experiences, and our new Patron website. And in our focus segment, we will review the 2023 final CMS payment rule and the updates to the Medicare Quality Reporting Program.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 174 of the ASC Podcast with John Goehle for November 15th, 2022, recording from Hilton Head Island, South Carolina. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and a Senior Nurse Consultant for Ambulatory Healthcare Strategies. The ASC regulatory environment is extremely dynamic, and the material provided in this episode is based on information available as of the date of the recording. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies. He is recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory accreditation and finance issues.
So we are supposedly on vacation down here in Hilton Head. We're in a nice little condo with our fancy new board setup here. You should see, she's giving me that evil eye look as we're trying to get used to this new setup here. It's not like being in the studio where all the equipment kind of does everything itself. Here, this is a little bit more confusing.
I always just do the same thing. I sit in front of a microphone. You have to deal with all the other stuff. But this looks like it's much more intuitive, and it's very colorful. And
it is very
easy
colorful.
To transport, way easier than the...
Yeah, we have a lot less equipment to take with us. But we're down here for about 12 days and trying to run a business at the same time that we're enjoying the weather. We got here just after that second hurricane hit in Florida, but it didn't affect us really at all. But we're trying to get caught up on some of our podcasts. We have about 3 podcasts we're hoping to get out in the next 3 or 4 days here. This one, we're going to talk about the 2023 payment rule. The next one will be on pharmacy, because we haven't talked about that in a while. And after that, we thought we'd do an episode, Sue, on recalls, because we really haven't talked about that. And there's been quite a number of questions about that recently.
Yep. And I wanted to say happy Perioperative Nurses Week this week.
And we're trying to recognize all of the different health care groups that seems like every week there's a different group. So this week it is Perioperative Nurses Week. Yep. Congratulations to hopefully everybody, all of your employers are treating you well this week. So we've been doing an awful lot of changes to the website. We updated the ASC Podcast website about 2 or 3 weeks ago, and it looks really sharp now. Very snappy. It looks a little bit more modern than it did before. We really hadn't updated it in almost 3 years, so It was well overdue for that. So please make sure you go up and visit. There's some new content up there, and certainly the links to the various podcasts are a little bit easier to follow now. And also, we are making some major changes to our Patron website. That's better known as ASC Central. So those of you that are Patron members, and we encourage everyone to become a Patron member, but Patron members are able to access a lot of different resources on the website. And over the next couple weeks and going into December, we're going to be opening this new Patron website up to all of our existing Patron members and hopefully all the new ones that join us soon. And probably one of the biggest things that we did is we opened up a new member group on LinkedIn. So I was looking at the various groups on LinkedIn, and I was trying to find one for ambulatory surgery center nurses, and I didn't see any. So I just created one.
Made your own.
So if you are following me on LinkedIn, name is John, John Goehle, Goehle. Follow me on LinkedIn, and you'll be able to see the new. You have to ask to become a member of this new group, but it's called the ASC Directors of Nursing and Nursing Managers group, and we're posting a lot of information there. I've been trying to, throw content in there. Hopefully other people will start throwing content in there also. But you'll have to ask to become a member. I'm approving everybody. Just keep an eye out for that new group, and we'll put a link to it in our show notes here also. So let's look at some of the recent news. Probably even though this doesn't impact surgery centers directly, physicians have been quite vocal in their frustration with the new Medicare physician fee schedule, which was released about the same time the CMS, ASC, and HOPD rates were released in early November. Unfortunately, the new physician fee schedule will reduce the reimbursement to physicians by about 4.5% almost. And this is going to have, unfortunately, some impact on the Medicare population as physicians are reimbursed less for taking care of Medicare patients. The decrease is primarily due to the expiration of the 3% payment increase that was provided for in the 2022 payment schedule that was passed by Congress earlier in 2022. And also because of some changes in the evaluation and management of the current procedural technology codes. So I think, as I said, I don't think this has a direct impact on surgery centers, but certainly physicians are going to be looking for other sources of revenue, and that usually means that they're going to looking to the surgery centers for that revenue. But it definitely could also have an impact on the Medicare population and the availability of surgical services to the Medicare population.
So I have some not very hard-hitting news for my first item. But I thought it was funny, any nurses out there know that we're always afraid to say, oh, it's a slow day, or, oh, it's kind of really quiet today, because we really believe that it's going to, suddenly we're going to, the worst things are going to happen. But there actually have been several studies that were done, which I think that's the most interesting part of it, is that I just can't believe people actually did studies.
Do these studies, yeah.
But they did, and they did find out that it does not actually increase your amount of patients. So I don't think that any of us are going to be convinced. I think we're going to still stay superstitious, but they actually did have some they actually did have some investigators or, researchers that went in to different healthcare facilities, and they would either use the word like, oh, you're very quiet today, or they would just go in and say, hey, how are you doing? And then they kind of watched and saw what happened. So it has been proven that it's not going to.
Okay, well, after that hard-hitting news there, yes. But very interesting news, certainly. What's going on with this family that was awarded a big dollar amount?
Yeah, this was actually very sad. So a family was awarded $21 million after a healthy 27-year-old man was left in a vegetative state following surgery for a fractured shin at a Dallas medical center. His blood pressure during the surgery had dropped while under a general anesthesia, which resulted in a lack of oxygen to his brain. The lawsuit alleged that the CRNA who provided anesthesia to the patient was being supervised by an anesthesiologist who was also supervising 3 other CRNAs at the same time, who were all in different ORs, of course.
Which is a very common situation, even in the ASC setting.
Yeah.
That they would be supervising 3 to 4 CRNAs at the same time.
Yeah, and it does say, this practice is allowed in Texas according to the policies of the anesthesia group. The patients, however, according to their policies, should have been informed that they had a choice of either an anesthesiologist or a supervised CRNA. And they also noted that although it's allowed, it's really not the best or safest care option. They didn't feel that the patients were properly informed and the consent. So that's something that we often end up talking about is, you have to make sure that people know who's providing their care and how that's being done. So
might be a good point to kind of reemphasize what an informed consent for anesthesia should include. And that should be not only the actual care provider, what type of, whether they're a physician or a CRNA, their name, as well as the type of anesthesia that's being provided. So that's something I've been finding recently on surveys, is that we're not finding that all of these anesthesia consents actually include the actual anesthesia that's being administered. Or there might be a checkbox that's not checked, or it gives a whole list of the different types of anesthesia that might be provided, but it is required that you actually have the patient sign off on the specific anesthesia that they're going to receive, as well as this lawsuit pointed out, who's providing that anesthesia service.
And it was so sad. The patient actually had come to the U.S. from Venezuela, and he had almost completed his engineering school. He was working at a job hanging Christmas lights when he fell off a ladder and fractured his shin. So, this should have just been a very quick surgery, and now he's 4-hour care. So it's just something to think about.
Let's talk a bit about some of our recent experiences. As we always talk about, we always have interesting conversations during our Saturday sessions with our Patron members. And again, if you're interested in becoming a Patron member, ASCPodcast.com. But anyway, the recent Saturday session, the question came up about food and drink in the clinical area, and the question was asked: where can staff members keep their coffee or their water or their food? And the answer is not in the clinical space at all. We did point out that if you were able to locate a section of your clinical space where there is no patient drugs, patient foods, patient interaction at all, you could have water there, in a closed container. Again, it has to be a closed container, but no coffee, no food at all, other than the food and the beverages for the patients. And that is another situation that I'm finding, unfortunately, quite frequently when I do a survey or even a mock survey now.
And one of the people on our Saturday session had mentioned that you could use a cart if you have an empty area that meets all the criteria that you were just talking about, but you don't have, a spot there, a counter or whatever. You could maybe get a cart that you keep covered and
roll
keep your things there
into an area that's not being used at that time. Yep. And Sue, I did a survey a couple weeks ago, which I thought found a couple things. I always learn something during surveys, but this one was particularly interesting. It was a survey that I did in Pennsylvania, and it was for a GI center, and they were using a system called GI Genius. Now, I don't generally like talking about specific brand names, but this appears to be one of the major products out there. It's an artificial intelligence that's used to identify polyps in a colonoscopy feed. So it's an intelligent endoscopy module connected to the internet and feeding a live image of the colon from the colonoscopy and comparing it to a very large database on the internet of polyps. And it helps to identify polyps that might be missed. And it puts a green box around a suspected polyp. It was just fascinating to me. I mean, I've seen hundreds of colonoscopies in my life, and this is the first time I've seen this artificial intelligence used. And I will say most of the ones that the system identified ended up not being a polyp. There was one that was identified as a polyp, but the rest of them were not. But it provided the physician with kind of another eye there to keep an eye out for things that he might have missed as he's kind of quickly going through the colon.
So the physician is also watching this image. This machine just sort of like focuses on, okay, take a look at this.
Correct.
Thing. Oh,
instead of what you're, generally in a colonoscopy, you have a television image of the colon, and you have to identify those polyps there. And over time, I've gotten to the point where I can actually see one too, and I don't know much about this, but those can be awful small.
And if somebody's tired, they've done a whole lot of them. I could see where you could kind of, just. It could blur in your mind, for a minute, so that having that focus has got to be really helpful.
And also being able to, in real time, do it as you're quickly moving through. I mean, they look several times at each of the areas of the colon, but this picks it up quite readily. I was very impressed with it, and I heard that it's not an extraordinarily expensive system, and I believe it's still in a testing phase right now, but definitely something that I would imagine is going to become a standard of care in the future. And then the second thing that I saw there really, I guess it doesn't take much to amuse me or impress me, is that they were using a language line Insight video interpreting, which is a rolling station with a camera, microphone, and a small television screen for a remote interpreter. So they, through the internet, they connect to a remote interpreter, live person who is, in this case, it was sign language. They were doing live signing, and the patient could see the interpreter, and the interpreter could see the patient, and in real time they were doing the interpreting, which is so much better than just that telephone, which has been the hallmark of the language line system. And they claim that they have over 40 different languages that they can pretty much instantly start communicating with your patients with.
So do they use the visual if it's not a deaf patient, or was that just because the patient was deaf?
It was, well, in this situation, it could be either for a deaf patient. It happened to be a deaf patient in this situation, but also the point that that language line makes is that it is so much better to not just hear a voice, to actually see a person when you're doing the interpretation.
Okay, so even with just other languages, they do have
Correct.
the person right there on the screen.
Yeah, and I think you pick up visual cues that you might not pick up on the telephone. So very impressed with. I have no idea about pricing of this, but and the instant availability of this interpreter compared to back in the day that I was running surgery centers, we would have to arrange for an interpreter. A couple weeks beforehand, that person would show up. You'd have to suit them up. All the different things you have to do. And this rolling cart just followed that patient throughout the whole episode. So definitely an incredible new technology there. And I'm sure there's other competitors out there that are going to be doing the same thing, or perhaps are already doing the same thing, but keep an eye out for that. And again, it probably is important to remind everyone that you are required to provide an interpreter to patients that come into your center if they do not speak the language of the care of the providers. And it is not the standard anymore. It's not really appropriate for you to use a family member for interpretation. That hasn't been the case for well over 5-6 years now. So it's just something to remember, is that you are responsible for either providing somebody that can speak the language to the patient in medical terms, or to provide an interpreter to do that. Let's take a break, and when we come back, we're going to talk about the 2023 final payment rule from CMS. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So in early November, the final 2023 payment rule, CMS payment rule for hospital outpatient departments and ambulatory surgery centers was released. We're going to provide a link in the website on our show notes to the full information about that. Let's start by talking about how the Medicare CMS ambulatory surgery center reimbursement works. So the current system that we have in place has been in place since 2008. And in 2008, they adapted this APC-based payment system, which is the same system that's used for the hospital outpatient departments, or HOPDs. Unfortunately, we don't get paid the same reimbursement rate that a hospital outpatient department gets paid. We get paid almost half of what the hospitals get paid. And the reason for that is there's a presumption that hospitals take on much more complicated patients, or patients that have a higher acuity level. So the way the payment rule works is the proposal comes out in July of each year, and and we talked about the proposed payment rule in July in an episode in July, and that provides some guidance to the industry as to what CMS is considering for the final payment rule. And then it's subject to a open period for discussion where the industry provides feedback to CMS, and then CMS takes that feedback and then determines whether they're going to accept some of the changes that are proposed or finalize the rule. And then the final rule, as we know, comes out in approximately November, as we have seen here. And what the impact of this is that it sets the Medicare reimbursement rates for the following year, so in this case, 2023. Payment rates are often used by other insurance companies as well as Medicare managed care providers. So even if you don't take care of Medicare patients, the payment rule is a very important part of your reimbursement cycle. It also establishes the parameters for the Medicare Quality Reporting Program. And we've talked about that program, Sue, over the last year quite a bit. And the impact of it. Weren't many changes in 2023, and we'll talk about that in a few minutes. But basically, the important thing to understand about the Medicare Quality Reporting Program, or the ASC QR, is that as long as you do all of the things that are required under the Medicare Quality Reporting Program, you'll get your full increase in your reimbursement rate, the Medicare rate. Otherwise, Medicare is going to reduce your increase by 2%. So, for example, this year, as we'll talk about in a second, the increase was going to be about 3.8%. If you did not meet all the requirements for the Medicare Quality Reporting Program, meaning that you reported all of the elements for the 2023 payment year in 2021, it's always 2 years back, then your reimbursement rate will be 1.8% instead of 3.8%. Now, there's another thing that we need to note, and that is that this is a very complicated system. And even though as we're going to talk about in a second, the reimbursement rate goes up by 3.8%, it is not a across-the-board increase. The increase will be different depending upon the results of the cost reports that are filed by the hospitals. Ambulatory surgery centers don't file cost reports, and therefore our information is not actually used in the reimbursement system. But the hospital cost reports are used to realign the acuity levels of each of the CPTs that are included in the APC-based reimbursement system.
So we should mention that there are some states that require cost reports, because I know they're a big pain, and I'm sure any New York state listeners are saying, wait a minute.
We don't do cost reports, right? As Sue just pointed out, the state of New York is the only state actually that requires cost reports to be complete, or at least comprehensive cost reports that look very similar to the Medicare cost reports. But the New York State Medicaid cost report is not used as part of this reimbursement system at all. So again, this is a complicated system. Every year, based upon the adjustments in the acuity levels, your case reimbursement could go up or could go down, even though the average increase is about 3.8%. So let's talk about the new payment rule. So CMS just published the rule on November 1st, and it will be in effect on January 1st, 2023. The Medicare reimbursement rate was increased by 3.8%, which was actually 4.1% inflation-based rate based upon the hospital market basket, with a reduction of 0.3% mandated by the Affordable Care Act, coming down to 3.8%. So this is particularly disappointing because, as we are well aware, the consumer price index went up by about 8% in 2022 and continues to keep increasing, or continues to go up. And we're not expecting that inflation rate to decrease until somewhere well into 2023. So this is going to make it this is going to continue to make it very challenging to offer pay raises to your staff, and of course that we know that wage inflation is one of our major challenges in keeping and recruiting staff at this time, as well as the average cost, or the increases that we're going to be experiencing or already are experiencing with drugs and other supplies.
And ASCA had proposed that 47 procedures would be added, but only 4 were actually added in the end.
And one was actually proposed in July. Mm-hmm. So we went from 1 to 4, but we wanted 47. So we're very disappointed at those results. I should note that the CPT codes are a copyright of the American Medical Association. All rights are reserved. CPT is a registered trademark of the American Medical Association. So Sue, why don't you tell us the lucky 4 procedures that were added?
Okay. CPT code 19307, which is a mastectomy procedure. Code 37193, which is percutaneous placement, repositioning, or retrieval of inferior vena cava IVC filters. 38531, inguinofemoral node biopsy or excision. 43774, which is laparoscopy, surgical gastric restrictive procedure, removal of adjustable gastric restrictive device, and subcutaneous port components.
So we are appreciative of the 4 that we're at, and they are actually pretty interesting cases. I'm not sure how frequently they're done in a surgery center at this point, but a very disappointing year, probably one of the smallest number of additions in this year. And then Bill Prentice had a interesting quote about this, which kind of summarized our whole feeling about these new codes. Go ahead, Sue.
So to quote him, CMS's decision to add only 4 new procedures to the ASC CPL for 2023 after ASCA proposed 47 procedures that ASCs are performing safely and successfully for privately insured patients is a serious mistake and denies beneficiary access to high-value care. Forcing otherwise healthy Medicare beneficiaries to receive care in higher-cost settings for these procedures needlessly increases costs to the Medicare program and undercuts Medicare's mission of serving as a responsible steward of public funds.
And of course, we've talked to Bill a couple times. A couple episodes ago, we discussed with him his thoughts on this whole thing. And again, please, we really want to make sure we emphasize the importance of becoming a member of the ASC Association. That's at ascassociation.org. They did a wonderful job, and even though they only got 4 of them through, they got 4 of them through, as opposed to the one that CMS had originally proposed. And then CMS is finalizing separate payment in the ASC setting for 5 non-opioid pain management drugs that function as surgical supplies, including certain local anesthetics and ocular medications. And the approved drugs and biologicals are those used in ASCs that are FDA approved, have an FDA approved indication for pain management or as an analgesic, and have a per day cost above the OPPS drug packaging threshold. By the way, those words are directly out of the CMS final payment rule. I don't necessarily know what they mean, but what it really is getting down to is that more information to come on which drugs and how much they're going to be reimbursed. And we're hoping that this is going to help pay for some of these medications, but you need to make sure that your billing department is well aware of this information as soon as it becomes widely available. So just pass this news on to them and let them look it up. And Sue, why don't we talk about Medicare Quality Reporting, or ASC QR?
Okay, so the 2023 payment rule does not include a requirement to track cataracts improvement in patients' visual function within 90 days. As you're aware, this would be very burdensome. For now, this is just voluntary, and the ASC Association continues to work with CMS to explain how this would not be an appropriate quality measure for ASC. So that was quite a relief.
It was, and again, it has not. They're still holding it off. It's voluntary. Mm-hmm. I can't imagine anybody voluntarily wanting to report this right now. And please don't. I mean, I think it's important as an industry that we stick to our guns and indicate that this is a very burdensome one. And it really doesn't have anything to do with the surgery center. This is if this is going to be a quality measure, it should be a quality measure that's put on the physicians themselves, because they're the ones that have control over this. Once the patient leaves the surgery center, we don't see them. Certainly, we don't see them 90 days later.
Get this information.
There were no other changes to the Medicare quality reporting requirements, which I guess is important to note that also means that the OAS CAP system, or the Medicare patient satisfaction component, has been held off until at least 2025. So we don't have to worry about implementing that program, though. As we've talked about in previous podcasts, it is important for you to start looking into, signing up with one of the approved CMS providers of these CAPS programs. And we're going to provide a link to the full CMS fact sheet, as well as the other information that came out as part of the 2023 payment rule. And with that, let's take a short break, and we'll come back and talk about some of the things that are going on in the industry.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
And our ASC Administrators Bootcamp for administrators, ambulatory surgery centers, and those looking to become CAS certified will be January 24th through the 27th, 2023. For more information about that and all the benefits of joining on our bootcamp, visit ASCPodcast.com.
And ASCA's 2023 Winter Seminar is January 12th through the 14th at Caesars Palace in Las Vegas, Nevada.
And I'll be heading out there to do a whole morning on finance and accounting. There's kind of like a mini boot camp, I would say, for finance and accounting at that conference. So for more information on ASCA 2023's Winter Seminar, visit ascassociation.org.
AORN's Global Surgical Conference and Expo 2023 is April 1st through the 4th at the Henry B. Gonzalez Convention Center in San Antonio, Texas.
And ASCA 2023 Conference and Expo is May 17th through the 20th, 2023 at the Kentucky International Convention Center in Louisville, Kentucky. And I'll be doing, I think, 3 speeches there, and Lori will be down there also with us, as well as quite a number of staff from the Ambulatory Healthcare Strategies group. So definitely visit ascassociation.org to sign up for ASCA 2023. And also, don't forget about our recorded events. They're all available on ascpodcast.com. We have a credentialing conference that we recorded in 2020. It was a full-day conference talking about how to do credentialing, provider credentialing in an ambulatory surgery center. And then in fall of 2022, we did a finance, accounting, and reimbursement conference, which is now available. We also did a conditions for coverage conference. The recording's available. We recorded that in 2021. It's a really good conference, Sue, right, for explaining all of the conditions for coverage. We're going to have to re-record that soon. And then also in 2021, we did a medical director conference, which talked to medical directors about the responsibilities that they have, particularly during a survey and what their responsibilities are as a medical director. And don't forget about our on-demand version of our Director of Nursing and Administrators Bootcamps. Those are newly revised, and they're available on our website at ascpodcast.com. And again, let's remind everyone to become a patron member of the podcast. Patron members help support our efforts here in maintaining this free podcast. And for $25 a month, you get a whole host of benefits. The patron program is also known as ASC Central. As we indicated, there is a brand new website for it. And it's an exclusive membership website that provides a one-stop ASC regulatory and accreditation compliance operations and financial management resource for busy administrators, nurse managers, and business office managers. The resources that are available include virtual conferences, links to various resources, policies and procedures, forms, drills, and other information, as well as access to free AEU credits just for listening to the podcast. And probably the most important part and the benefit that everybody seems to enjoy is those Saturday drop-in sessions where you can meet via a private Zoom link with other patron members and talk about things that are going on. We usually talk at least an hour, sometimes an hour and a half every Saturday morning. It's not every single Saturday, but it certainly has been for at least the last couple months. And membership does help defray the cost of producing the podcast, including our research staff, travel costs to conferences, equipment cost, and the production cost. And for more information, of course, you can visit ascpodcast.com. And that's it for this episode of the ASC Podcast with John Goehle. And please spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Caloritis, Amy Durbano, Lori Rodericks, Kathy Foti, Donna Macchio, and Ann Geyer. Music is provided by Media Sushi and Mike Noah. And the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, Trivalence, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable insights. Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.